Hello, Facebook. Thank you so much for connecting with YWCA Dayton. We're going to get started in about 2 minutes at 12:05, but thank you for joining this amazing and impactful conversation that we're going to have today, reckoning with racism in medicine and our pathway forward. So we appreciate you joining us today. We've got a couple minutes and then we'll get started. Thank you, everyone. Camera going. All right, let's go ahead and get started. Good afternoon, everyone, and thank you so much for joining us for our very first YW discussion of 2020. We have an incredible panel of experts lined up for you, so we're going to go ahead and get started. My name is Donna Long, and I'm the Director of Advocacy and Outreach at YWCA Dayton. YWCA Dayton, for those new to our organization, is the oldest social services organization supporting women and children in Montgomery County. YWCA Dayton is on a mission to eliminate racism, empower women, and promote peace, justice, freedom, and dignity for all. We are a champion of women and girls in 3 ways: direct service programming, community outreach and education, and advocacy and in public policy support. I'm at YWCA Dayton. We operate the only domestic violence shelter and rape center in Montgomery and Preble counties. The only domestic violence shelter and rape crisis center in Montgomery County and Preble counties. We provide affordable housing and support services for women and families who are victims of abuse or experiencing sudden or chronic homelessness. We empower teens to achieve their highest potential through Girls Lead and engage men and boys in preventing violence against women and girls through Amend Together. We advocate for legislative priorities that address racial justice and civil rights, women's economic power, and women's health and safety. You can learn much more about this critical work if you log on to ywcadayton.org. Today's discussion. Our topic today is reckoning with racial trauma in medicine, and we also want to discuss the pathway forward. We want to honor and lift up what's happened, but we also want to position ourselves to move forward, to make impacts in the now, and moving on to our future. If you participated in any of our 21-day racial equity and social justice challenges, you remember reading about the history of medicine and healthcare in the United States that is marked by racial injustice and a myriad forms of violence. This includes unequal access to healthcare and segregation of medical facilities and exclusion of African Americans from medical education, and so much more. Ensuring quality, affordable, culturally competent healthcare is one of YWCA's advocacy priorities. So we thank you for joining today's YW discussion, but we'll be talking about this year and beyond. For many women and children, people of color, and trauma survivors, getting the medical care and insurance coverage they need is a struggle, and unequal access to healthcare is a driving factor to racial inequities and racial inequities and disparities in maternal and other areas of health outcomes across the United States. Together with disparities in housing, employment opportunities, wealth, social service provisions, we know that these long-standing inequities produce disproportionate health outcomes by race. We know that. As our nation grapples with COVID-19 pandemic, especially, it is critical right now to confront these painful histories to develop more effective anti-racist public health responses and to show up in agency for our own healthcare to build healthy families, because without healthy families, we cannot have healthy Black communities. So let's get in today. I'm so proud to introduce to you today's panel. We're going to follow the then, now, and how pathway through this discussion. So although we're talking about trauma in medicine, we want to hit what happened. We want to lift that up. We want to share that, but we also want to move to what is our responsibility now? What agency do we have now? And then how? How do we exercise those things? Each panelist will have about 7 minutes or so to share their perspective and knowledge, and then we'll leave time at the end for questions. So if you're joining us via Zoom, please feel free to put your questions in chat. If you're with us via Facebook, put your questions in the comment area. So on the call today, we have Gina McFarlane-El, who is CEO of Five Rivers Health Centers. We have Phil Walker, a medical student at Wright State's Boonshoft School of Medicine. We have Dr. Anim. She is the Chief Medical Officer of Five Rivers Health Centers. We have Fabrice, Juin, Project Manager with the local Office of Minority Health at Public Health, Dayton and Montgomery County. We have Taylor Curtis, Professor of African American Psychology at Sinclair. And we have YWCA's very own Manicka Thomas, Associate Clinical Director at YWCA. So thank you, panel, again for being with us today. So let's begin. We're gonna begin with the then. So Taylor, I'm gonna turn the floor over to you so you can talk to us about what happened then and the role that trauma played, particularly through health for Black and Brown Americans.
Absolutely. So we all are aware that we went through the transatlantic slave trade and we watched individuals be ripped from their cultures, ripped from their homes, ripped from their people, their language, their traditions, and moved and forced into labor here in slavery here in the United States of America. That experience alone was extremely crucial when it comes to the mental breakdown and the physical breakdown of the person of color. We look at them being changed from their eating habits, their ability to provide resources for themselves, the traditional herbs and medications that they were used to using. All of these things were gone now, and they were now treated as property, no longer valued as human beings, no longer in an ability to have what they need as people. And that in itself involves a lot of trauma. And that trauma not only comes through the physical experience, but the mental experience. In the Willie Lynch letter, which is a conversation about how slave owners should treat their slaves, there is a saying that stands out that said, break the body, break the mind, keep the body, right? Break the will, keep the body. But they also broke the body in the process. So individuals went through heinous experiences physically from the beatings and the torture that they experienced, as well as the harsh conditions with the lack of resources. And then moving beyond that, when we got out of slavery and now we're looking at how people of color did not have the same rights as everyone else, the same rights to healthcare, the same rights to benefits, the same rights to the same quality of that. We witnessed also experiments that were done on people of color that reflected extremely negatively of people of color based off of the data that was produced, but it also reflected on the distrust that was building between people of color and the medical field. We can look at people like J. Marion Sims, individual who is well known as a father of gynecology and who is known for creating different tools and methods and surgical procedures. But all of those things were created by experiments on people of color without their will, without their consent, and without proper treatment of them. This individual was to the point of doing experiments on children to where he actually used a shoemaker's tool to pry apart their skulls because he believed that their skulls grew too quickly around their brain, and that was causing some difference between behavior of people of color versus white people. So when we start looking at the history of that here in the United States, we witness many other scenarios. One that's pretty famous that people talk about quite often is the Tuskegee Experiment. This didn't happen much long ago. This was not hundreds and hundreds of years ago. We're talking about that Bill Clinton was president when he apologized to the nation for this heinous experiment against people of color, where individuals who already had syphilis were targeted for an experiment where they were not given any type of treatment. They were told that they were being given shots. They were told that they were giving cures, but they were actually just being watched to see how this disease completely destroyed them as a person and how they physically broke down over time through blindness, through a lot of physical ailment beyond that, a lot of pain and a lot of suffering. And individuals died, even though an actual cure to syphilis did exist. But that wasn't the first time that American government even did that type of experiment. There was an experiment beforehand in 1940s in Guatemala, where 700 men and women who were prisoners of the United States were tortured through being given syphilis. They were actually given syphilis for the sake of study. And so when we look at those types of experiences, or the experience of a Black woman being toured around Europe for her body and because of the differences of her body, or when we start to look at even current day research that suggests that our medical students are believing that there's a difference in the skin of people of color versus the skin of white people, or the pain tolerance, and then looking at how that impacts individuals. When we start to watch this experience of a power structure that is behind a support system that's supposed to be there for the people, and it not being catered to the people, you see a lot of not only distrust of the medical system, but then you see people not getting the care that they need, not getting the education that they need about their health care, and then also not getting the support that they need within the community. And so it is a long-standing experience. And Harriet Washington wrote a great book, Medical Apartheid, that outlines several of the experiences of people of color in medicine. And then witnessing now, as we look at maternal mortality rates, and we look at infant mortality rates in the Black community, and we start to see how that plays a role in the disadvantages and the racial public health crisis that we have in our community today. And then if you start to look at other things within the Constitution and amendments, you also see how things like redlining and housing restrictions and restrictive covenants prevent people from being in areas that are going to support and have the resources. And that redlining causes the hospitals to disappear out of the communities of color and to be placed in the suburbs and in areas where people may not be able to access or may not be able to afford. So there is a long-standing history of that.
Thank you, Taylor. It is infuriating, and the more you read, as James Baldwin said, you can find yourself angry every single day at every single moment. But you talked a little bit, and woven in all of that is the trauma piece, right? So Manicka, you're in a leadership role here at YWCA, and you have worked prior and are working with women and families who we serve that are healing from trauma. Tell us more a little bit about the impact of trauma, because the story is, or the judgment is today, when people of color don't show up for health or are aggressive, coined as aggressive in the doctor's appointment, then that's viewed as being difficult. But there's some trauma behind that. So does generational trauma show up in the work we do today? And how do we address it in our own selves in order that we can get the things that we need today medically?
Thank you for that question, Donna, and thank you so much for that, Taylor. You hit all the points, so thank you for that history lesson. So one of the things that I like to do before I discuss trauma is kind of define what it is. So one of the ways that I define trauma is any life experience, any stressful life experience that's either unpredictable, overwhelming, or chronic. Chronic meaning that it happens over time. Unpredictable, obviously meaning that it wasn't something that you planned for. Overwhelming means it overwhelms your nervous system. So we all have a specific window of tolerance, a amount of stress that we can handle within our own lives. And when a trauma happens, it is outside of the proportion of the level of stress that our body is able to maintain. So when that happens from a clinical perspective, we look at potential diagnoses that can be at play. One of those potential diagnoses is complex PTSD, or PTSD in general, which is post-traumatic stress syndrome. And with that diagnosis, it has the same characteristic of experiencing something that was overwhelming, unpredictable, or chronic. So a few things that we're looking at there are hypervigilance, meaning you're always looking around your environment, wondering if you're safe. You might have a lot of anxiety around certain situations or with particular doctor's offices. We see this a lot with women who have experienced trauma within the medical health profession. Taylor hit the nail on the head when she mentioned about the distrust that's there, but then also that stress tolerance or the pain tolerance, meaning that sometimes doctors feel and have felt in the past that Black women have a higher tolerance for pain. So one of the things that we have to be mindful of is when we're thinking about trauma and a trauma response, it is activating our nervous system and it is having an impact on how we view the world. And when we think about how our brain works, our brain in our body is designed to keep us safe. So it's very protective. So our brain is always scanning the environment to see if there are any threats or potential threats that we have to protect ourselves from. So then our body goes into our fight, flight, freeze, or fawn response, meaning our body is looking at the environment for a threat or a potential threat. That threat can be a physical threat, an emotional threat, a psychological threat, anything that our body gives us that red flag or that alert that says, okay, something doesn't feel right, or this doesn't look good, or I remember this before and it didn't turn out well for me. So our body gives us those signals and those signs to protect us and to keep us safe. So when we get those signs, sometimes those signs come up when they're not warranted. It's simply from history, what we've experienced, what we've gone through in the past, but we need to know if those triggers are something that we should be responding to physically, or if it's something where we're needing to learn to calm our stress system and our responses, because we can begin reacting to things, which can be that hypervigilance, where we're responding to things where there's really no potential threat. So when that process is happening, you also want to think about how you're perceiving your physical environment. So not only is hypervigilance present, but sometimes with PTSD, you'll notice flashbacks or nightmares about a particular situation that happened. You'll notice a heightened startle response. So if a woman has had a particular situation and it did create a lot of activation in her body, her trauma response will be activated around similar situations that happened to her in that regard. So we have to be mindful of that, because one of the things that we look for, especially at the Y when we talk about trauma-informed care, the trauma-informed care model says that we don't look at what's wrong with you, but we ask the question, what happened to you? So that changes the lens and it changes the perspective, where we're not judging the behavior, we're not judging what we see, but we're going a step further and we're getting a full picture of the narrative and the story and asking the question, if you're presenting in this particular way, what happened to you in your life that will cause you to have these responses and that will cause you to present in this particular way? So I think that is one piece that's really important. So Donna, you mentioned about the impact that it has. So it does create high levels of anxiety. It creates the ability for us to put off any signs or symptoms that we notice that are happening in our bodies. We are not responsive to the things that we should be taking care of. We might have just a general distrust about the medical profession. And we also have some cognitive dissonance around the experience, whether or not it's real. We question, we sometimes say, well, I'm not claiming that, or, I'm not going to speak that into existence. But it can be a really harmful thing that's impacting our body, but because we disassociate with it, we don't accept it as something that we need to pay attention to. And that's one of the other pieces that can happen with trauma, where we have this disconnection between mind and body. So all of those pieces are really important when we're talking about women and them becoming advocates for their mental health, because dissociating from a situation, that's sometimes the natural response. But with trauma, you have to be able to work through the trauma. You have to be able to understand the mental capacity of where you are, how it impacts your body. And a few things that we look at in therapy is we look at the frequency, the intensity, the duration, and the onset of any presentation for mental health. So we're looking at how long does it last? When did it begin? How does it show up? And how frequently are you experiencing those things? So women should be in the habit of asking themselves those internal questions to decide whether or not they should be acting on any mental health condition that they observe, any physical health condition that they observe, anything that they're noticing differently that's happening with their bodies. So in terms of what to do, you want to begin working to activate and increase that connection, that brain-body connection that is oftentimes disconnected when a trauma is present.
Manicka, can you list those steps out again? Because I want us to be able to provide that information.
So in terms of looking at if a mental disorder is something that you need to be responding to, you want to look at the frequency, the intensity, the duration, and the onset. And then you want to begin reconnecting that brain-body connection, which is oftentimes disconnected when you experience a trauma.
That's good. Thank you. Thank you so much. So I love that, because then it gives us steps. Now, I think anybody that I've talked to, I've shared that I'm a 12-step person. I need to know what it looks like. How do I do it? And then when do I go to the next phase? And I think if we're working this out internally so that we can show up, it's important to know the steps. So thank you. Thank you so much, Manicka, and thank you so much, Professor Curtis. I want to start moving now, transitioning a little bit into the now. My two panelists who are going to speak in this space, please feel free, if the now discussion, if there's relevancy in going back to the then, to pull to the now. Phil and Fabrice, please feel free to do that, to build your conversation. So I want to start with Phil. You're joining us as a current medical student. What are some of the things that you're learning and seeing that you hope to use to transform not only the next generation of medical providers, because we talked a little bit about that and how some things are already baked in. So we might need to attack this thing from a different space, but share with us what you've learned, what you've observed being on the other side.
Yeah, so Donna, I think, thank you again for this panel. This has already been amazing. I mean, Taylor and Manicka, you guys have already like blown my mind, speaking on some things that I kind of knew about, but I hadn't fleshed out in the same way that you all have. I'll say one of the things that I'm noticing being in medical school is when you speak about students being prepared to go out into the physician workforce, some of my classmates, it may take them a little longer to recognize trauma because they haven't experienced it, or they haven't experienced it coming from someone who looks like us. And I think one of the issues with that is when you miss things, you ask the wrong questions, or maybe you don't ask enough questions, or maybe you don't know when to push deeper. And I think one of the things that we do in the first year of medical school, we have these simulated patients, and we get patients to come in and we ask them a series of questions, kind of a scripted sort of list of questions, but they'll throw a monkey wrench, and they'll have patients come in and be distant and not want to answer the questions. But they have patients come in and throw us curveballs with like a bunch of information that we don't necessarily need. And what I saw immediately coming into medical school was some of my counterparts struggled with being able to pick up on what was going on with Black and brown patients. So it would be the same person that everyone would be, I wasn't sure about, I wasn't clear about. And when you think about it at this level, okay, you get dinged on a test. But when you think about how that carries for 4 years, and then you go become a physician somewhere and someone's life depends on it, it becomes a big issue. And I came in with the class of 2020 at the School of Medicine. So class of 2016. Class of 2020, I came in 2016. So my classmates are all first year residents this year. And that's terrifying to me for some people, because I know that they aren't necessarily prepared to address their own biases. I know they didn't spend time doing that in medical medical school. Quite frankly, there's not a lot of time to do that in medical school. So we have, I know me and you, Donna, we spoke about like implicit bias training. We have those things, but I mean, it's not a real incentive to address it. You can go to the training, you can check off that you did your time, and then you can move on to the real work. And we've had students openly complain about the fact that there are like population health and community health sort of things woven into the curriculum, and they feel like it's a waste of time. And so I say all of that to say, I think when we speak about now where we are and some of the things that we, me being in the process of going into, the physician workforce and being in front of patients, I think one of the things that we're seeing is that physicians on the whole are ill-equipped, right? Even those of us who have experienced trauma in various forms, we're not equipped. And I think that even when we were just speaking, and this is kind of a tangent, but we were thinking about iatrophobia, which is just the fear of like, physicians and medicine. One of the things I was thinking is in a practical sense is the strength in numbers. So you've seen people as a group, right? So people are much more bold when it's 5 of them versus 1. So one of the things I was thinking as you were talking, Manicka, is why don't we as a community agree that no one will go to a doctor's office by themselves, right? So if you have a grandmom, you have a mom, you have a sister, let's just agree as a community, we don't necessarily have to do anything other than be present. And I think, my wife is African-American, my mom is African-American, my only sibling is African-American, which is my sister, and both of her daughters are African-American. And I speak to all 5 of them every day. And every single time they have a health issue, I'm like, I wish I could be there. Not just because I'm in this field, but because I know as a male, I have privilege. And I know I'm going to get a certain level of respect that they might not necessarily get, and which has been proven that they aren't getting. And so, I mean, just some of when we think about practical ideas, I think we want to get too grand. And I think we want to attack the system, and we should. And that's our work to do. But I think we also have to realize that there are much smaller, easier commitments that we all can do that change how we are treated and how we are, quite frankly, mistreated in some instances. And I, Don, I can talk, so if you.
Well, there are a couple of questions that I have for you, and I want to put this up, and I want to put this up for Phil, for Dr. Anim, for Gina. So when Phil talks about, medical students, and surely Dr. Anim, you can attest to this, and some things being baked in, some things that they're just not even thinking about tuning in on cultural competencies or how Black folks might present in the doctor's appointments. For those people who are, I want to show up for myself. I want to, go to the doctor. I want to be able to be healthy and not only, really stay in tune with my preventative appointments. How do we advocate for ourselves? Or what are your recommendations for us advocating for ourselves in the doctor's offices, before the doctors and nurses who have no clue about cultural competency? I mean, we're not going to go in there and list all of the traumas that we've had in medicine, right? But how do we show up for ourselves? Are there any questions or anything? I think this is kind of a general question, but how do we show up for ourselves in the face of those who have no clue about our history, our trauma, or why we present in the ways that we present sometimes? So let's go with Dr. Anim.
Okay, so it's a great question because, the answer is superficially simple, like just tell them what you want, but it is very complicated.
Yeah.
And, Phil said a lot of right things, that in medical school, we're not teaching our students how to deal with people who don't look like them. And so, unfortunately, if Phil will tell you, the medical students, for the most part, learn their clinical medicine from the residents, who are people who just finished medical school, and they're just passing on their knowledge. So most of the time when they're seeing a patient, they're not seeing it with some professor who has been seeing patients for years. They're seeing it They're learning from somebody who pretty much just got out of medical school, is also doing their residency learning and is surviving. And so there's a lot of literature showing how these stereotypes and these bad behaviors just keep being passed on from learner to learner to learner. And guess what? Then these learners eventually leave. The other thing I wanted to mention is a lot of residency programs are taking care of patients in clinic settings, patients who typically are the medically underserved and have a high percentage of people of color. And so again, these are patients who may not be, have health insurance, may not be as health literate, and don't really know how to stand for themselves. So they learn that, okay, these patients don't know how to stand for themselves. And sometimes when you fight for them, they don't even want to listen to you.
Right.
So having had that concept, that stereotype keeps passing on. And this is kind of the foundation of why we can't get better, because we learn in an environment that sort of reinforces these stereotypes, and then they go out and then they carry the stereotype to them. So bring it back to, you've decided, okay, now I want to do better. So first of all, you're talking to somebody who unfortunately has this baked in stereotype. One of the things I say to my patients, and especially my sickle cell patients who find themselves in a lot of these conflict situations, is I know when you're sick, the last thing you want to do is to think about how to talk to somebody and sort of be nice.
Yes.
What I've realized is that if this is how you're going to get what you need, you've got to play nice. I mean, it's difficult. But if you antagonize everybody around you, you don't get the care you need. It shouldn't be that way. You shouldn't have to be thinking about playing nice when you're sick. But until we do better as a system, that's part of what you have to do. You have to learn. And I've heard people say, you know, I know, I want to say something else, but I say something else because I realize that if I go that direction, it's not going to help me.
Right.
All right. So we speak up for ourselves, and I really try to take emotion out of it, focus on the facts, speak up for yourself, but, you know, just focus on the facts and don't get the baits. Now, we're not stupid. We can see when somebody is discriminating or stereotyping or treating you unequal. You can tell. And I think if you can find a way to say that without emotion, when people are called out and they're called out without having a way to blame you for because you were mad, because you said some other word, then you make a difference. So if you can find a way to call people out, but without emotion, without using harsh words, but focusing on the behavior and the fact of what happened, I think that's how we stand up for ourselves and get the care that we deserve.
Yeah. Yeah.
I just want to add, in racial trauma care, we say make the invisible visible. So even if it's not in a very direct way, perhaps asking, you know, would you note that in my chart or something of that nature, it makes the invisible visible without you attacking the person.
Yeah. A personal example of that, two of them actually. I remember I was having some like heart palpitation. There was something going on. I'm like, what is going on with my heart? So I called my doctor and she's like, well, just go to the emergency room. So I go to the emergency room, and now this was maybe about 8 years ago. And so I check in and the lady's not even looking at me. She's not even looking up. But then she asked me my age, and I think I might have been, you know, in my 40s, something like that. She looked up, and then she saw I was African-American, I'm in my 40s. And then there was another question that she asked that immediately caused someone to come in with the wheelchair to take me back. So there's key indicators, right? I had a friend who is now diabetic, but didn't know that he was at the time. And, you know, his doctor was like, well, you know, we'll get some blood work in 3 days. And I'm like, 3 days? So again, called my doctor, and she said, well, tell them, you know, tell them this and tell them this. And so we went to urgent care. He told them that. They got his blood work immediately. You know, there were certain things. And then I have heard, and I don't know if this is true, but if you're having, as a woman or as a patient, issues with your body, and you know that something's not right, and your doctor refuses to give you the care that you need, by saying to the doctor, can you record that you're unwilling to give me this test? Or can you record that you're unwilling to send this referral for a scan? Does that make any impact in what happens next?
I mean, I think that would make somebody pause to think, do I really want to go on record for refusing care? I mean, I know that sometimes patients want things that really, it has nothing to do with it, because somebody told you that when I had this symptom, this is what they did, but you're listening to them and you're looking, it's like, this is really not the same thing at all. I really do try to work with and explain that to them. But, at the end of, and then we also are supposed to be sensitive to, running tests and, increasing costs of care. But at the end of the day, if I have told you everything and I have done everything and you still want that test, I mean, I will do it. I'll tell you, it may not be covered and all that, because you do your due diligence and you do the work. But sometimes part of treating people is giving them the peace of mind. And I realize that, because sometimes peace of mind is what they need. It's not just me saying it's going to be okay.
Yeah.
It's me saying it's going to be okay because I did this and this is what it showed.
Yes.
And so it's that patience and trying to say, if it was me and if it was my mother and if it was my sister, what would I do?
Yeah.
That's, I think, what makes a difference. And that's what doesn't happen enough. People don't put themselves or their loved ones in the shoes of the person sitting in front of them. Because when you do that, you stop and you say, I would probably say, just get it so that you feel good enough. So it is, sometimes it's out there, but at the end of the day, if that's what's going to make that patient better, it may be worth doing it.
Yeah.
Can I just, to answer your question earlier, Donna, you were asking about if you are a patient and you're saying, I want to advocate for myself and I want to exercise my agency, where do I kind of start? And I think, not getting too deep in the story, I'll say that I had a friend in college who underwent 4 liver transplants, and she was so aware of her diagnosis. She knew everything about it. She had no medical or science background, but she just knew everything about it. And she ended up passing away. And I remember after she passed away, I kind of really bought into this idea that we are able to educate ourselves. She had no formal training, but she was on it. From the equipment and everything. And so my thing, and I won't get into it too much, but my thing is health literacy, right? I really, really, truly believe that health literacy is important. And I think that when we speak about health literacy, people may think that you're expected to have the knowledge base of a physician, or you're expected to know every single word. You're expected to basically speak Latin. And that's not the case. I don't think that we need to, again, go to the extreme. I think what we need to be able to do is leverage what we have in our hands, what we have in front of us, which are phones and computers. So unlike refinancing, for example, I can't Google what questions to ask before I go to my lender. If you're going to the physician and you don't know the diagnosis, you can't say, I'm going to come prepared for what they're going to say, because you don't know what they're going to say. But what we can do is, when we get that homework, go home and really dive into it. I think we put a lot of energy into so many things. We are so knowledgeable about celebrities' relationships, and we know what did happen, and we know everything about it. But we take one Medscape or one Google about a term, and that's enough for us. And I think that, obviously there is only so much you can understand, but the more you know, the more you show the physician, hey, we can have a higher level conversation. I don't have to dumb this down for you. You are not someone who is incapable of grasping this concept, because a lot of concepts in medicine are not that hard, to be honest. There's just so many of them, but it's really, these are things that you can find an analogy for almost everything. Yeah. So I think one is doing that homework when we get home, but I think also when we speak about advocacy when things go wrong, we need to put things in black and white. My mom always tells me, unless it's in black and white, it does not matter. And what we tend to do sometimes is have these experiences, myself included, I just had an experience with my wife maybe a month ago. We'll go through these experiences and we'll speak amongst ourselves about how bad it was, but we won't go and leave a Google review, right? And I think I heard somewhere that you can't delete Google reviews or something like that. Yeah. But if we want to get, like if we want to get the attention and hold these people accountable, us speaking about it amongst ourselves doesn't put anybody's feet to the fire. But if we can say, like you said, Dr. Anim, with facts, at 3:05, this happened. At 4:02 is when I got a response. I was, discharged at this day. If we can put those facts online and galvanize around a collective saying that this provider is not okay, or this person, because we know that within our communities. We say, oh, don't go to so-and-so. You know what I'm saying? We know that, but it's nowhere in black and white. Yeah. You know what I mean? And so I think if we just, and not just, and I'm scratch the word just, because there's so many layers to this, but I think, again, when it comes to advocacy, there's advocacy on the front end, there's advocacy in the middle, and there's also advocacy on the back end. So yeah, let me stop again, because
Well, you're making an incredible transition to Fabrice and in public health. And at YWCA, we've testified multiple times at the Ohio State House to say that yes, racism is a health crisis. What I want to know, Fabrice, is talk to us about what you guys are doing over at Public Health to kind of help combat that, and then speak to us about health literacy options, ideals, thoughts, practices, and then if you could also share with us a little bit about any information that you have on the vaccine and kind of what you guys are seeing in that space as well.
Okay, that's a lot. So let me know if I'm missing. But just to start things off, I think first and foremost we have to realize that reckoning can and should happen on both ends of the issue, right? And that there certainly needs to be some form of reconciliation with the occurrences of the past. And this is just touching on the then, obviously, and how that connects with the now. As we mentioned, there are traumatized communities who have been pushed to the wayside and left to fend for themselves, a crisis after crisis, disaster after disaster, injustice after injustice. And now in relation to the current COVID-19 crisis that we're facing, these same communities are being asked to trust the very institutions that may have previously let them down, right? So that's a little bit of disconnect there. I bring this up as a needed first step because the issue goes beyond, the makeup of interpersonal trauma between one person or another, right? Where healing and progress can sometimes be initiated solely by the individual, whether or not the other party is involved on their own. So the trauma we're referring to relates to institutional offenses and environmental circumstance. We can't continue to act like the members of these marginalized communities just wake up every day and willingly make negative health choices. For the vast majority, that's just not the reality. I think about my father, who came into this country as a Haitian immigrant, received a trade school degree, could not find employment opportunities to take him, and instead had to opt to drive taxi in New York City for 12 to 15 hours a day, 7 days a week, while only having enough to pick up any street meal he could afford to make ends meet for our household. After a decade of that, weight and heart issues have been a part of his daily life for a while now. And every time I get an urgent phone call, I'm wondering, is it another mini heart attack, or is it something that's happening to him? I think about my Haitian mother as well, who couldn't access health services without having myself or my father present to help her overcome language barriers. So obviously these are things out of their control. What really happens is that their hands are forced because their surroundings and circumstances don't always allow for self-betterment and self-improvement, whether through under-resourced education options, environmental racism that keeps people in such desolate areas and living conditions, or medical mistrust that can be difficult to shake. These are all real-life factors related to one's built environment as a social determinant of health. So in these instances, that door towards self-improvement and self-betterment must be open to provide the opportunities that folks need to take that first step to not just making their health a priority, but also having the avenues to actually pursue that in an intentional and fruitful way, right? That door has to be open first. As I mentioned in previous conversations, I strongly believe that our society has made some significant strides in opening this door by recognizing and acknowledging the issue to allow for our underserved and under-resourced to finally be prioritized and for their unique needs to be met. On a local level, I can point to public health resolutions to implement the health equity in all policies approach and our declaration of racism as a public health crisis as examples of this. Long overdue, but definitely necessary public commitment. So as far as how, and I guess this also ties into our vaccination efforts, because while there still needs to be work for the direct resource allocation into these declarations, it just simply stating it and putting it out there, putting it on paper and presenting it to the public has given us the justification needed to provide vaccination opportunities that are specific to Black and African community members, to provide vaccine messaging opportunities that educate and empower folks to make the right decisions for them. So, you know, even if there's still more work to be done, just that statement on paper, yes, you know, allows so many other moves to be made to follow it. So as far as how individual persons can show up for their health and capitalize on this ongoing narrative change, if you will, I think a few things come to mind. If you have insurance, use it. Do not wait for a medical emergency to be the only reason why you step into a medical or health facility. Get your regular physical checkups, schedule your dental visits. Don't leave any health issues that come up unaddressed, no matter how small. And if you don't have health insurance, connect with your community groups, like our amazing Fabrice Health Center, to find out what healthcare options are available to you. If you have the privilege of a reliable internet connection or a phone line, you know, do your research, as Phil mentioned, and reach out to any qualified contacts you have. You know, and the keyword is qualified. I know we love getting advice from family or social media, obviously, but vet those. You know, vet those. I love my aunts and uncles as well, but sometimes I gotta be like, is that true? You know, as I grow up, I realized so many things I was taught, they were just playing with me. But definitely, you know, do that research and figure things out for yourself and educate yourself despite what's being given to you, even by the professionals too. You can get insight from professionals and still check in on it just to make sure you understand it fully. In relation to women's health and those unique challenges, if I can, I just wanted to push, if I could push anything that would encourage those that are more experienced and well-equipped to take others under their wing, right? So family, coworkers, acquaintances, and I think Phil mentioned it with that presence piece, but if you've been successful at navigating the healthcare system, making the most out of your grocery runs on a tight budget, maintaining physical activity with a packed schedule, or prioritizing self-care, share that knowledge to empower other women around you that are open to receiving that guidance and direction. I think there's just a lot of power in connecting those that have figured it out with those that need a hand to help close that gap so we can all progress together. So that's kind of the 2 cents as far as how we can move forward, but at the same time, we do need to recognize that there are certain parameters and limitations that the circumstance and environment do hold us back from.
Yeah, and self-care, I mean, even me, you know, I have to force myself to stop. And I don't know if it's a psychology, you know, if it's something in our, as Black folks, DNA that says you got to just keep pressing forward. You got to just keep pushing forward and feel bad about taking a pause. You know, Manicka, what'd you say?
It's not in your DNA, Donna, but it is in your cells, because we pass that on generationally, and we've passed it on, that compartmentalization and that keeping it to yourself and holding it in and still being able to separate and go do something else. That has been passed on through our generations. And then we believe that, you know, that is good enough. So you got to take care of yourself.
Yeah. And I
I'm just going to add in. I also just think from the standpoint of realizing who is the expert on your body, and it is you. And sometimes we're so busy focused on what everybody else says is wrong with us, but we need to look at what's going on from our own standpoint, going back to the facts. And I would just kind of add on from the standpoint of, you know, I feel that every appointment, medical appointment, emergency room, hospitalization is an opportunity for you to state what's wrong with you from your perspective. You know your body. You're with yourself 24/7 all the time. So sometimes just taking the time to write down what took place and when. So when you get into that medical appointment, you can state what took place. I always coach all of my family members, bring a notebook, bring a person and bring a notebook. And part of it is that sometimes there's so many things going on, and unfortunately, there's so much medical jargon going on. You may not hear everything, but that other person may. Or take that opportunity to talk to that medical person and say, hey, listen, can you repeat what you just said? I know you're going to put it in an after visit summary and it's going to state it here, but I still want to make sure I understood exactly what's going on. We have to go back to the basics of we are our own expert on our own body. And I would challenge Phil a little bit too on just the social media and a Google review. That's all dead fine. But to me, why not call that person or call that organization back and say, hey, listen, I had a less than satisfying experience. And let me explain to you what took place. Now, for me, that's the courage that we need as African Americans, is to say, listen, something just didn't work out. And I would say a lot of our managers spend probably 25% of their time going through those issues and trying to figure out, okay, was this a systematic issue or was this a one-time thing? Was it some way that someone came off in an inappropriate way? Then we need to work on them and coach them. And, you know, we can continue to do all the cultural competency work that we need to do, but we need to focus so much on just taking care of that patient and what their needs are.
Yeah.
Similar to what Dr. Anim said, is really listening to what people are saying.
Yeah.
And you can only do that by having a conversation, having a brave, courageous conversation to say, hey, listen, Gina, that was not the best experience that we have. And I would say with Five Rivers, one of the things that has, one of the blessings that we have as being a federally qualified health center, 51% of our board are made up of the patients that we serve. Mm-hmm. So Dr. Nim and the rest of us, every time we're at a meeting, we have something called patient experience. And they tell us what went well and what didn't work out. And that's how they've been able to advocate for us to get on a better path of doing things that we never thought we'd do. But at the same time, it's listening to the voice of the patient. That Google review is fine and it will stay there forever. But if you really want to make a change, have a conversation with that person who has the power to make that change and make a difference.
Yeah, and go ahead, Phil.
Okay, sorry. No, I definitely agree with you. And I didn't want to make, I don't want it to be thought that I was saying that's the only way to do it. I definitely agree that get on the phone is a big deal. And I think it's important. I will, and I'm gonna challenge you back. I will say that oftentimes the people who have the power look like the oppressor. So if you call and say, hey, I'm an African-American woman, I had a bad experience. Oh, okay, yeah, we'll get on that, right? And fortunately, we have places, and this is changing now, right? Where some of the people who are charged with holding some of these positions and administrators accountable are starting to not only look like us, but even if they don't look like us, understand what we're talking about and understand that it's not just like we talked about, this angry Black woman stereotype or this aggressive Black man stereotype. So I agree. I think all of it should be done. Make a call, Google Voice, tell your friends, put it on Facebook, whatever you need to do. But I think my point was just that we need to hold them accountable in a way that it gets to them. You know what I mean? It can't just stay within our communities, our feelings. But I want to touch on 2 points, and I promise to be real quick.
You're fine.
The one point you spoke about was that everybody's body being different. And one of the things that I've learned about medicine early on was that we all are like a fingerprint. I heard this term epigenetic fingerprint the other day. Like everyone's body is completely different. And I think one of the issues that we have as a community when it comes to the distrust that we have with medicine and science is that we don't understand what this game is. The game is that we've taken centuries in some fields and maybe decades in other fields and collected a whole bunch of information. And we're making a very, very, very educated guess on what we think the billions of cells in your body will do for a given treatment or a given disease. And we don't know that. So what happens is we have this confirmation bias. Oh, well, the doctor said my grandma should only have 2 weeks and she lived 4 years. I'm not messing with Western medicine. or the opposite. You know, the doctor said that things were going to be good and it went bad. You can't trust, you know, we had an adverse reaction. I can't trust Western medicine. And I think when you go into a space looking for someone to betray you that you already feel betrayed by, and you have a false management of expectations, we're not going to get out of that. So one of the things that we have are people saying, well, you know what, I'm not listening to Western medicine. I'm not taking any of those pills. They just want to charge you money. They just want to, you know, get you for whatever. And my thought to that is, be like my sister, right? My sister will say, I'm not listening to the doctors for certain things, but she will then go become, you know, an avid, obsessive reader of whatever, you know, whatever it is she decides that she wants to do. She won't just say, well, they said that CMOS will cure whatever I got going on and leave it just at that Facebook post. She will then say, what, you know, why are you saying that? What are the properties? What is it? And she may make an educated decision on what she's going to take and what she's not. But I just wanted to make that one point that I am seeing that a lot with people around me. Like I said, my sister, my family, my friends, where we're taking this distrust that we've always had, but now we have new information and people saying that they know so much about medicine and we don't need to rely on Western medicine. And we're not treating that with the same level of skepticism. And we're blindly, in some cases, leading each other down this hole of things that don't have any scientific basis. So I'll stop again.
Well, I mean, yeah, you take a good point, very interesting point, because there are a lot of homeopathic options, right, in this space that we don't want to get too far into. But I think Dr. Anim mentioned it, and I know that Manicka talked a little bit about it. I think Gina did also. I think having the courage when we have bad experiences, when we feel overlooked, unheard, when we are overlooked, when we are not heard in the physician's office, to find the courage to have that conversation, managing our expectations in that, but having that conversations and not moving in a place of full emotion, like Dr. Nim said, but sharing what your experience was, and you don't feel like you were seen, you don't feel like you were heard, not sure why, but I don't feel like my issue was addressed. What is our next step? You know, not just leaving a period there, but I think Fabrice mentioned also having the literacy to be able to articulate that in the moment is a challenge, right? For a lot of people. Manicka, I want to talk a little bit about the mental aspect of all this, right? Because we know that a lot of things that manifest in our bodies that we have to go see a physician for, or we have to start taking a homeopathic pathway, we can maybe manage a little bit before they manifest. So let's talk about the importance of mental care in our communities as a form of self-care.
Yeah, I think that's so important. And I was listening to all of those different pieces as you all are talking. And I think it's a difference between having this conversation with people who have a normalized experience that's not rooted in a trauma versus people who have an experience with the medical profession that is rooted in a trauma. Like a person who's not had a trauma that's impacted their nervous system, they're operating at a different part of their brain. Now, I have a social worker's understanding of the brain, but I know that when we make decisions, when we make good decisions, we're operating at that executive functioning level of our brain, the prefrontal cortex, where decision-making, problem-solving, good choices, all of that happens and takes place. When you're in a trauma response, you're operating at the base of your brain. You're at the survival level, meaning how can I stay safe? Is this gonna harm me? You're scanning the environment, as I mentioned before, about a threat or perceived threat. So we have to know where people are in those brain states, meaning you can be in the survival state, you can be in an emotional state, and then you can be in the executive state where you're making those good, important decisions. So if a woman is operating from a survival state, she's only thinking about, am I gonna die? Is this gonna kill me? Am I gonna be safe? Am I gonna survive this? Like just the basics around survival. So we have to be able to move women from from the survival state to an emotional state where they can kind of incorporate and ingrain some of the feeling part back into what they're experiencing, and then move to the executive functioning part of the brain.
Yeah.
Because if you notice any apathy with women or them not wanting to follow up on their mental health, that apathy can be misconstrued, because really what underlies apathy is fear. So if we're not dealing with those underlying instances of fear that are coming up for women, then we can sometimes be missing the mark. So I would just say, knowing what brain state women are in. So if you notice that a woman has experienced trauma, she's probably in a survival state where she's probably just thinking about, what do I need to do to survive? If you're wanting to move her out of that brain state to make decisions like what we're talking about, choices, going on Google, those sorts of things, then we have to move her to that executive functioning part of the brain. Because if she is experienced trauma, that executive part is cut off. She's not even able to tap into that. Yeah. So we have to be able to create safety, which is through community, which is what some of you all mentioned, having connection with a friend, a family member, having connection with community, having conversation to help alleviate that stress response, bring it down to a normalized level so she knows that she's safe, she doesn't have a reason to fear. And then you want to be able to challenge those core beliefs that women have. So the negative core beliefs is I can't trust, because that can be tied to a deeper memory. The situations in my environment are fearful. That can be tied to another underlying trauma that they've experienced, but it's playing out in all of these different areas of her life. So we have to, in terms of a therapeutic setting, we have to be able to undo the connection with some of those messages, because the thing about trauma, it changes our brain function. It changes the connections that we have in our brain, and it rewires our brain. So we have to be able to disconnect some of those connections that women have around certain experiences and give them a new frame of reference in terms of how they're experiencing the world, and then how they're perceiving their bodies. Because a lot of women who've experienced trauma, they don't have a way to really connect and listen to their body. They don't even trust the messages that they get as it relates to their body. So then we have to work through those pieces as well, is when you are experiencing these things, how do you know that you need to respond to this? How do you get that connection back? So those are some of the mental pieces that we have to be able to be mindful and considerate of when we're dealing with trauma.
So what are some of the practical ways that someone can do that, just kind of on a daily, maybe not a daily basis, but to care for ourselves mentally? When we talk about self-care, maybe not in going to the doctor's office, but just in our day-to-day lives, how can we better nurture ourselves mentally? Because there's a stigma there, right? Going to a therapist. Maybe not so much now, but I know that there has been in our culture. So what are some of the small practical ways? If I'm not ready to like go sit and talk to somebody because they're gonna think I'm crazy, what are some of the practical ways that we could take care of ourselves mentally?
Well, I'll mention one, and then Taylor, I know you deal with psychology, so if you want to jump in too. So one of the things that I do in a therapeutic setting is I do cognitive behavioral therapy techniques. So what that does, it looks at our cognition, our thinking, how that's tied to our emotions, and then how that connects to our actions. So one of the things that I get clients to do is to think about how they're thinking. Think about the narratives, the stories that they're saying to themselves, meaning I'm not safe, I can't get through this, what if I die? Is this curable? What about my children? Like all of those questions, which can create a lot of anxiety. So I have them identify the thought. And then once they identify the thought, I work with them on stopping the thought, challenging the thought, and then telling yourself something true. So stop the thought, challenge the thought, tell yourself something true. So we go through that process with all of the things that they're thinking about that's creating increased anxiety, that's creating fear, worry, doubt, guilt, all of those emotions that interfere with our ability to care for ourselves. And then we just go thought by thought and work through that process, stop the thought, challenge the thought, tell yourself something true.
Very good.
And to build off of that, Manicka, I think that telling yourself what is true is something that you can also do every day. So some people do self-affirmations where they tell themselves what they believe is true about themselves, or what they are working on, or kind of manifesting who they are looking to be, how they are looking to be treated, and telling themselves what they're inviting in their life, what they're releasing out of their life, and what they're claiming over who they are. And doing that on a regular basis, whether you got the energy to look in the mirror and do it, or whether you you record yourself and play it when you're having a rough day, just getting yourself into that mindset on a regular basis. Like Manicka said, you're rewiring your brain. So it has to be constant. It has to be happening actively, because that active stimulation is what causes that rewiring to happen. So that, as well as finding self-care or coping strategies, things that help release that stress, whether it's things that are going to be physical, like working out, exercising, meditation, grounding, earthing, things that you can do that physically give your body a release through the different chemical messengers in your brain that are being released at that time. That's one way. And then there's also the emotional things or the mental things, getting it out, putting it out, writing it down, journaling. Some people like to journal and then they go back later and write when that thing has changed or when something has changed with that situation. A friend of mine just got me a Give It to God box that was just like a little cute little gift box, but she said, just write it down and put it in the box and let it go. Sometimes that physical action allows you to release some of those things. And when we hold on to that trauma all the time, it causes the physical to then go into health responses. Your immune system is compromised. Now you got headaches and migraines, gastrointestinal problems. And then it also affects your mental health and the depression and isolation and anxiety. So it all goes together. And then being with people, finding a support system, building a support system. We have to do this, especially in the community of color. We have to stop isolating and holding in our issues to ourselves. We have to start speaking out about it and speaking with other people who are going through it. I recently went through a situation myself where I had to have surgery. It was unexpected. Turns out I have stage 4 endometriosis. I was seeing a Black doctor for 7 years and thought because she was a woman and because she was Black that she would understand what I was going through and that she would listen to me and I would be heard. And I realized that I wasn't being heard and felt like I wasn't being heard. And I finally went and got a second opinion and had someone, take care of me right away and identify what I was dealing with right away. In that experience, I later had family come out and say, I've had that same issue. I've had that same experience. We need to talk about this more often. Don't wait until it is happening. Do it ahead of time and encourage the education and that health literacy, not only about health in general, but health about your family and your family's history. Because some of those things are like Donna said earlier, you could say, here are some key things that will cause a doctor to look deeper into this situation if we say those up front. But having that community, that support system and sharing of information with one another, sharing of experiences with one another is another thing that really helps with people's mental health, especially as it pertains to medical issues.
Yeah, absolutely. I mean, this piece is so critical because sometimes we feel paralyzed in how to show up for ourselves. So I thank you, Phil. I thank you, Dr. Anim. I thank you, Fabrice, Taylor, Manicka, for talking about now. How can we stand in agency now in the face of everything that is going on systematically, right? In and through the trauma, right? Getting that second opinion. Key. Sometimes we feel like we just need to stay where we are, but we don't have to. So getting that second opinion is key. Like Fabrice said, using our insurance when it's not an emergency room visit, when it's not something that is immediate. Use our insurance. We have it, and if we don't have it, we're going to talk in the how about some services from Five Rivers. Taking someone with you. You're right, Gina, when you're in that place, whether it's a general visit or if there's something more serious, you are in a kind of a state of anxiety, whether it's heightened levels or just, that interest of fear. And so you're not hearing, you're not remembering. I remember going to the doctor with my mother and, they had said a term, I didn't know what it was. So I Googled. So then I began to ask questions about what I saw it meant, what the word meant. And so writing, having somebody with you, never going alone. So thank you, Phil, for that. I think Gina mentioned that as well. And then seeing about ourselves mentally and so many other areas that we talked about that we're going to capture to be able to share with those who are watching and who are with us. I want to move now into the how. We have Five Rivers Health Centers with us. We have Gina McFarlane-El. We have Dr. Anim to talk about services, to talk about what do you do if you don't have insurance. Can you talk a little bit about that right now?
I'm going to start off with, let's say you have no insurance whatsoever. I'm talking about Five Rivers Health Centers, but there are other federally qualified health centers just like Five Rivers Health Centers that can help you too as well. And especially between now and May 15th, there's an opportunity for people who don't have insurance or got laid off because of all the things going on with the pandemic, where they could apply to see if they qualify. So when we started Five Rivers before the Affordable Care Act, about 45% of our patients did not have insurance. As soon as the Affordable Care Act kicked in, we have what we called our outreach and enrollment counselors who helped people get on insurance. So we've gone from 45% of our patients not having to only 9%. And that 9% are people, primarily it's because of their immigration status or that's probably the main reason why they don't have. But there's so many people in this community who can get on Medicaid or other services that are available for them, but they just don't ask. And so it's a free service. You don't have to be a patient of Five Rivers Health Centers to find out whether or not you qualify, but you can go to any of our Five Rivers Health Center sites and we can find out whether or not you qualify. And again, this is a perfect time between now and May 15th, now that open enrollment was reopened under this new administration. Talking about just services of things that we've been able to do. So when we first started, we focused, well, because of resources, we only had medical services. Since then, we've realized that medical is just not enough. And so we've expanded our services to, we have a dietitian available. We've integrated behavioral health with medical. So at our sites, you can see that behavioral health consultant at the same time you're seeing that physician or that nurse practitioner. And for a lot of patients who have to make travel arrangements, having everything at one location has been a godsend. We provide transportation for our patients. We use Uber Health. We'll get you from your house, get you to your appointment, get you back home. We have a pharmacist that's available. We have a psychiatrist. We try to focus on all of those social determinants of health. And so for some of our patients, they need legal services. So we have medical legal partnership where we have found some of our patients have asthma, but because their homes are infested with roaches, they can't get the landlord to do what they need to do. But by working with our lawyer, they're able to turn that around for that patient. We provide, many of our patients live in what's called food deserts. We've been partnering with a group called Produce Perks for our pregnant women, where we provide fresh, free, organic produce for them once a week. If we can't provide it for them, we will give them a voucher to one of the stores where they can go to. We do cooking demonstrations so that they can see how to use those vegetables. They may not remember how to use it because most of us aren't gardening the way we used to, but it gives them an opportunity to really try to hone in on those particular recipes so we're not buying as many processed foods.
Yes.
From our perspective, we as an organization really try to focus in on those quality of health issues that are going to impact our patients. We've been working with a product that sits on top of our electronic medical record where we can dig a little deeper on what's going on with that patient, or look from a population health standpoint on how can we provide multiple services for patients who didn't get their hemoglobin A1C, their blood pressure is out of control. And so over the years, we've been able to create lots of programs to kind of focus in on that. And so our Healthy Start program has focused on infant mortality. And the majority of the women that we serve are African-American. Before COVID, we were able to do home visits. Now we do drive-by visits. But at the same time, we find out, hey, or if you are going through a trauma, what can we do to help you? What can we do from the standpoint of any resources you need? Do you need to finish high school? Do you need a job? So all of those components are a part of the services that we provide at Five Rivers Health Centers.
So it's the whole person, it's the whole patient. It's not just the physical part. Now, is there a household income cap that that your patients have to fit into?
So that's the beauty, that we have what's called a sliding fee scale. So regardless of your income, again, if you have insurance or if you don't have insurance, we can find something that works for you. So I'll give you an example of our Latino patients who are, some of them were uninsured. So we created a sliding fee scale for those patients who are part of our Centering Pregnancy Latino group. And through that, we came up with a flat fee for them of how much it's going to cost for them to get their 8 prenatal visits. And for them, it's just opened the door for that partnership with each other while they're in their group setting, but also getting the OBGYN care that they need to as well. So again, when we find a need and we're not meeting it, we talk to our patients tell us, and we try to figure out a way how to make it work for them.
Yeah, I love that coordinated healthcare, patient care, because I know you guys can relate. Like if you call someplace and you give them your story, then you get transferred to somebody else, you got to give your story again. And you know, that used to be so frustrating. So to be able to have a comprehensive visit when coming to Five Rivers, I mean, that's amazing. That's amazing. And then you're kind of speaking to that barrier of transportation, that barrier of childcare. Maybe you can't, you know, if you're a single parent or if everybody in the house works and you're trying to juggle childcare, having to go to 5 different appointments on 5 different days can be a challenge as well. So thank you so much for that. Wow.
Can I, real quick, I just want to take an opportunity to say thank you to you, Ms. Gina. I really appreciate it. And I think one of the things that we don't highlight as much is that we have champions like you that the general public doesn't understand about how much you do and how much it plays into what care they actually get. You mentioned so many things. And I mean, it took a lot of things. It took everything but a medical degree to come up with some of those programs and some of those ideas. You don't necessarily need to go to medical school to be a champion, which you are. So I just want to say thank you, because I know, again, in medicine, I've seen how we give out flowers, and I know that the flowers rarely go to people who don't have a white coat on. So that's you know, amazing, and I appreciate it.
Now, Phil, you talked about a program that you started, and forgive me if it's not, if program's the incorrect word, but where you partnered with Premier, and it was a barbershop kind of concept. Can you talk a little bit about that?
Yeah, so as I mentioned, my friend passed away, I think it was my first year of medical school, and I got really interested in health literacy. So we had talked, her and I had spoke about, you know, starting a nonprofit based around health literacy. And shortly after she passed away, my wife and I decided to create it. And luckily, my barber, I was telling him about this idea since, you know, maybe March or so. I had been telling him, you know, our barbers, we tell them everything, right? So I'm telling him my hopes, my dreams, you know, what I'm going through with my family. I'm telling him everything, but I keep telling him about this idea of health literacy and why it's so important to me. And I was telling him, you know, I'm in medical school and I'm learning all this information. It's exciting, it's new, but none of it is getting back to my community. Like I'm here and nobody back home is being able to benefit from this because I'm busy and I'm the only one here. And so we talked, and he came back maybe a couple months later and was like, you won't believe what happened. I sat in my other client sat in a chair, and I just had a conversation about them wanting to do something with health literacy. So they connected us, and essentially the initiative with Premier was about bringing healthcare to Black men where they are. And Fabrice, you spoke about this, your father and him having heart issues and cardiovascular health disproportionately affecting African Americans, but devastatingly Black men, right? And what we decided to do was just incorporate all these health screenings. And what we allow patients to do, or clients to do when they became patients, is we would bring that health screenings to the barbershops, and we would say, hey, while you're sitting and waiting for a cut, you can come in here and get your hemoglobin A1C checked, you can get your BMI, you can get, you know, resources. We had nutritionists on site. You can, you know, engage in different like challenges with the barbers, with other clients. And it, for me, was one of the most rewarding things I've done since I've been in Dayton, because I really got to see how much it made a difference when I was able to sit down and say, you know, what's up, bro? You know what I mean? And speak the language and say, look, I can explain to you what a hemoglobin A1C is. I can explain to you what a BMI is and how it may or may not be useful, you know, because of how it was built and who it was built for. You know, I can play certain roles, but I think it was a reminder of, you know, when it comes to health literacy, sometimes what it takes is, of course, your own agency and you taking the initiative to go seek out information. But a lot of times, we as people who are in healthcare, we need to go out and get back into our communities. I mean, information, unless you bring it back, is useless, in my opinion. So it was an opportunity for me to do that. And I felt like I would have to wait until my journey was over. So me being able to kind of curb that whole system and say, hey, I'm going to find a way to get back and give back and be in that community with something was important to me. And I learned so much just speaking to people in these spaces. Just, you learn so much about how common our experiences are. I know we all, through music, through movies, we all bond over the trauma that we go through, but we don't bond so much over the everyday struggles that we go through. Like, unless it's like, you know, bullets flying and all that, we tend to gravitate towards, oh, we all can relate to that, but we don't relate to, like, hey, my dad has an issue with a prostate, your dad has an issue with a prostate, everyone in here's father, you know what I mean, is probably, you know what I mean, those conversations aren't in movies, they're not in rap songs. So it was just really interesting. I love it.
I love that. When you said that, I'm like, well, and I'd heard a little bit of something about that I think in another city, but I wasn't aware that it was here in Dayton. So I would definitely love that information, if you're still doing it, to share with friends of YWCA and beyond. So thank you so much for that. We're almost at the end of our time. I can't believe it. I'm not sure if there are any questions from Facebook or from our chat spaces that anyone wants to address. Let me see if I can. Let's see. Okay, this is always the balancing act.
Just the second one, as far as you know, people declaring racism as a public health last summer, and what are we doing, or what can we do about it? The one thing that I do know that is occurring is that there are lots of small groups that have been meeting to talk about it. They're meeting about it with regards to not just healthcare, but institutional racism that is going on in the educational system, things that are going on in government. Join those committees, like join those subcommittees, and then include your neighbor in that subcommittee too as well. Because those groups are going to be the groups that actually start putting together a plan of action. And you know, if you don't know what's going on, look online. Usually you will find on which particular area that they're dealing with. I think at one point they started with criminal justice, but I know healthcare is coming soon. I know we have a group through public health, Each One Reach One. We're always looking for community members to be a part of our committees on how to reduce infant mortality, how to improve the health of women. And we're always looking for community members. Just reach out to any of those groups, and we'd love to have you on those committees.
Yeah, I would like to add to that, Gina, that there are other different things that are happening in your community. Look and see what opportunities you might able to engage in, even if you can't make a commitment to be on a committee. So for example, like the Gym City Market, right, is addressing the food desert in the Dayton, Ohio area. You could be a member of that for $10 a month. That's what your Starbucks or your DoorDash for the day, right? You could do those types of things where you can invest in or just partake in and be a part of the community by being a part of those types of initiatives.
There's one question, and this could go through a whole rabbit hole, but what role do you see health insurance companies playing in closing these gaps in care?
So when we talk about gaps in care, I mean, there are gaps in doing your screenings or gaps in these systemic issues where people are being treated differently. Now, when it's gaps in doing your screenings, the healthcare companies are actually incentivized, and they incentivize us, the healthcare providers, to close those gaps. So it is the way the ACA is set up. Again, they are incentivized to make sure that you get your mammogram and your colonoscopy and you check your A1C if you're diabetic. So that's something that we continuously are working on with them. And they give you your data. So they are into that. The systemic problems that we're having, I really think that this is, it's on us as healthcare providers. There's just so much ingrained in our system, and there's so much of these stereotypes, and we just make decisions and we say words that are just terrible, and we don't even realize it. And we trigger people, and then we blame them for reacting. Mm-hmm. And so there's just a lot of that. I think it has to happen in healthcare. We need to recognize that we are part of the problem. And it's not just historically, presently, we are still part of the problem. And we need to acknowledge that. And by starting that acknowledgement and having that conversation, we can start working towards change.
Yes. Because
until we do that, people are still clueless as to why somebody's upset, but they just did something that really upset them. Mm-hmm. And people are still clueless. I just had a patient tell me the other day, I was really sick, I was in pain, I couldn't sit still, and the doctor's like, you need to sit still, you give me a history, and I'm in so much pain. And they called security to come hold me down. And I said, what? So these are the things that we're doing and we're still doing. So I think systematically healthcare, the hospitals, the doctor's offices, the clinics, we need to look at ourselves. I think anytime that somebody is upset or somebody doesn't, we need to really stop and think, what did we do? Because we are part of it. It's not a one-sided issue. We own about 70% of the problem.
Yes. Thank you, Dr. Anim. Well, we are at time. What an amazing conversation. I thank each of you for giving an hour and a half to YWCA, your friends forever. Thank you so much. Thank you for everybody who tuned in, who registered for this event. Please be on the lookout for more conversations like this to come in the future. So we thank you so much and wish you a great day. Bye-bye.